Parents of a child with a diagnosis of autism spectrum disorders face many decisions about treatment and intervention. Children with ASD often receive therapy in many different areas, including physical therapy, occupational therapy, behavioral therapy, and speech-language therapy. Throughout this presentation, we will present several options for different therapy programs that have been proven as beneficial interventions for working with ASD. We will also present some potential therapy goals that you could use while working with young children ages 1 to 5. In general, speech-language intervention is needed for young children with ASD because children with this disorder often have trouble with language, specifically social language. As SLPs, it is important that we consider each child individually because autism presents along a spectrum, and a treatment that works for one child might not be appropriate for others. When selecting a treatment plan, therapists should consider interventions that enhance developmental process and improve functioning relating to the core behaviors associated with ASD, including social communication, emotional and behavioral regulation, and adaptive behaviors. It is also imperative to involve parents in treatment for young children because parents need to be taught skills to best communicate with their child, and parents need to be shown how to actively enhance communication at home. Early intervention is ideal for children with autism, and each child should already have a plan in place for behavioral and developmental intervention by age 3. Now, Meredith is going to share with you more about specific interventions for children with ASD.
Another option for intervention is augmentative or alternative communication, or AAC. AAC means that either an alternate means of communication can be used to augment a child's speech, or it can be used as an alternative means of communication altogether if the child is nonverbal. There are high-tech and low-tech forms of AAC. Low-tech, some examples are sign language. Some children with autism who are nonverbal respond well to learning signs as a basic means of communication. So like for functional words like more or all done or please or stop. And then the benefits of sign language are that it's convenient and that it doesn't require any materials, so you can take it with you anywhere. But some of the disadvantages are that it's not an effective method for everyone. Individuals who have fine motor deficits are probably not going to be good candidates for learning sign language, and also it limits who you can communicate with. So if the person you're trying to communicate with doesn't understand sign language, then that doesn't really work. Another example of low-tech AAC is the picture exchange communication system, which involves teaching the child how to exchange a picture of an object that they want for the object that they are asking for. And the key idea behind PECS is that the clinician or the parent waits for the child to initiate the interaction, which is good for individuals with autism because it teaches them that, like, hey, if I communicate, then I get what I'm asking for. And the goal with PECS is to move the child up to communicating at the phrase or sentence level with the pictures. So they start out by just handing the individual picture to the clinician, but then the goal is that they'll eventually be like forming sentences by putting multiple pictures together. Some benefits of PECS are that it's inexpensive and not overly time-consuming, and it's easy for parents to implement at home or to add to it as the child increases their vocabulary. Some examples of high-tech AAC devices are speech-generating devices, which are devices that speak for the child. And the downside to speech-generating devices is that they're expensive and can be really complicated to use. They can also be really heavy, depending on the brand and the type that you get. A common myth associated with AAC is that teaching children AAC will reduce the likelihood of them developing speech as a verbal means of communication, but there have been several studies that show that AAC can actually have a facilitative effect on a child's speech. So that means that teaching them to use AAC can actually be kind of a gateway to them developing verbal communication later on. And one study found that the use of speech-generated devices increased the spoken vocabularies of the participants. And they speculated this is because they are hearing a verbal model all the time when they're using their generated device. And so that helps them improve their vocabulary.
see. Hold on. You're cheating. Thank you. Oh. Go! Hold on. Puzzle! Let's get a bug. Ladybug! Good job. Thank you. Ladybug. Can you give it to Daddy?
Can I have it, please?
Give. Good
Thank
job.
you.
Puzzle! One thing with PECs is they say you're not supposed to say, give me the picture. Don't. Because then he's not initiating.
Something that a lot of us might be familiar with. So ABA is a treatment approach that utilizes principles of learning theory to bring about positive behavior change. It helps children generalize skills like communication and social skills to other situations. So one of the most important things about ABA is that it's comprehensive and includes a full range of life skills. Another important thing to remember about ABA is that it focuses on the everyday. So communication, self-care, readiness for school are all important parts of ABA therapy. So ABA is often used in intensive early intervention to address a full range of life skills. Programs are often 25 to 40 hours per week for 1 to 3 years in both structured and unstructured settings. And in some states, special qualifications are needed to provide true ABA therapy. The second one is functional communication training, which is a behavior intervention that combines maladaptive behaviors, so things that we don't want to see, with ABA procedures, what I just talked about, to teach alternate responses. So this kind of therapy works well for aggression or self-injury or communication that you don't want to see. And the problem behavior is eliminated and replaced with more appropriate forms of communication. And one of the best parts about functional communication training is that it can be used across a range of ages and regardless of cognition level or expressive communication abilities, because you're teaching exactly what you want to see.
Okay, but uh-oh, we don't have all the pieces. So I need you to tell me what we need to get so we can play. Nice sitting, Daniel. Very good. What do we need to get?
The lid.
What's that?
Lid.
Get the lid. Okay. I like your sitting. Here we go.
The big lid.
Oh, the big lid. Silly me. Of course. Here's the big lid. Great thinking, Daniel. What else do we need?
Popcorn.
Popcorn. Okay, you stay in your chair. I'll get the popcorn. I've got the popcorn.
Put the lid.
Put it in. Okay, here we go. Da-da-dum. Nice staying in your chair, buddy. What else do we need? Oh, it's on.
Tap.
We need a cup. Okay. This one?
Yeah.
You want that one? Okay, there you go. And I'll get the red cup. Here we go. Let's turn it on. All right, let's get them. Oh, got one. Oh, got two. Your turn. Oh, can you get it? Oh, good try. All right, well done.
So far, the Early Start Denver model, also known as ESDM, is based on a child's strengths and weaknesses, specifically focusing on the development of social communication skills through intensive one-on-one therapy, peer interactions in the school setting, and home-based teaching. So ESDM is child-led and play-based for children aged 1 to 4 years of age. So skills focused on include communication, joint attention, imitation, sharing of emotions, play skills, and social orienting. The model integrates a relationship-focused development model with the practices of ABA. Although ABA is shown to be effective at producing behavioral change, there are slow gains and practical intervention hours per week.
And research has also demonstrated that teaching kids in a natural environment leads to greater generalization and accelerated learning. So ESDM emphasizes ABA principles combined with interpersonal engagement through synchrony, rhythms, and reciprocity to decrease symptom severity and accelerate cognitive, social, emotional, and language development. So for example, a child may be playing with a toy in like a rhythmic pattern, and the therapist will initiate an interaction with the child and copies the child's motor, emotional, and relational rhythms so that they can work in tandem. Another feature is that the parents can be trained, and so this parent delivery also leads to an increased generalization and the maintenance of skills than when compared to an intervention administered only by therapists. So it's been found effective for children with ASD across a wide range of learning styles and abilities. A randomized control trial by Dawson and researchers in 2010 showed that kids who received ESDM therapy for 20 hours a week over a 2-year span showed greater improvement in cognitive and language skills and adaptive behavior, with fewer ASD symptoms than children referred to the intervention that was commonly available in their community. And so overall, it seems like a promising intervention for young children with ASD.
The next intervention is floor time. This is a relationship-based intervention. The goals of floor time is to deepen the relationships, strengthen communications, expand thinking and learning, and foster better behavior. In floor time, you use this with your child to excite her interest, draw her to connect to you, and challenge her to be creative, curious, and spontaneous, all of which move her forward intellectually and emotionally. As children get older, floor time essentially morphs into an exciting back and forth time of exploring the child's ideas. For any child, you do 3 things: follow your child's lead, challenge her to be creative and spontaneous, and expand the action and interactions to include all or most of her senses and motor skills, as well as different emotions. Floor time is an evidence-based intervention. The research demonstrates that it strengthens fundamental communication, relationship abilities for children with autism. These improvements in the core deficits occur because of floor time's foundation in child development.
1, 2, 3. Are you gonna do it to yourself? Oh, right at Caitlin. 1, 2, 3. Oh,
Good shot.
what did I get? Who am I? One, 2, 3. Wow! 2, 3, boom! 1, 2, 3, boom! Wow! I got it too. Oh, don't touch you. Ouch. Just hold one.
All right, so cognitive behavioral therapy, also known as CBT, is not used to treat ASD specifically, but primarily is used to focus on the secondary issues, such as regulating emotions, developing impulse control, and improving behavior, while also teaching individuals how to become familiar with these feelings and behaviors and manage them. It's also been shown to help reduce anxious and depressed behaviors by making changes in thoughts and perceptions in situations through a change in cognition. So it can be individualized, and as a result, it's effective at improving specific behaviors in each child. So the therapist will adapt or adjust CBT to meet the strengths and the needs of each individual. And since those with ASD are usually concrete thinkers, the therapist may modify CBT to be more experiential and concrete than usual. So the child is encouraged to challenge both his beliefs and automatic thoughts through a variety of techniques. He may be asked to view his thoughts as a possibility instead of a fact, to self-talk or coach himself in replacing negative thoughts with positive thoughts, or to rehearse future situations and go through steps that will help him cope. The second part of CBT is psychoeducation, which involves teaching the child about his condition, so why he's having difficulty and how to identify the condition that's affecting him, and also how to interrupt it and stop. So CBT will help the individual to better read social interactions and read others' interactions more accurately, so they can monitor and adjust their reaction and behaviors and responses. CBT helps kids to work towards self-acceptance and use compensatory strategies to ease the impact of the things that can't be changed in everyday situations. And so the key component that distinguishes CBT from the other therapies we've discussed so far is that it's working on a changing cognition and how thinking is processed to help individuals achieve their goals.
The next intervention is social stories. Social stories has shown to have a positive impact on the social development of children with autism spectrum disorder since the 1990s. A social story describes a situation, skill, or concept. The goal is to share accurate social information with a client that is easily understood. Most are short stories that describe a specific activity and the behavior expectations associated with that behavior. They can be read by a caregiver or independently. They can also be presented audio or with video equipment. It is important to monitor progress once the intervention has been introduced. This method is best used for children with high-functioning autism.
Are you ready to earn your ice cream? It's time to get your first star. Wait to be seated by the hostess.
Hello, is it just the two of you?
Yes, and if there's a table in a quiet part of the restaurant, that would be great.
Sure. Follow me. Your server will be right with you.
Buddy, great job. You've already earned your first star.
Yay! Woo!
Hello, my name is Steve, and I'll be taking care of you today. Can I interest you in something to drink?
Yes, and I think I know what we'd like to eat. I'll have the chicken Caesar salad and an iced tea, and Buddy, they have some of your favorites. Pizza, macaroni and cheese, or a sandwich.
Pizza, pizza, pizza!
Buddy.
Pizza, please.
Okay, buddy, pizza it is. I'll bring those out as soon as they're ready.
Good job, buddy. You just earned another star. Tell the waiter what you want to eat and drink.
CERTS is another model that we can use with kids with autism as an intervention. It is developmentally grounded and family-centered. It stands for social communication, emotional regulation, and transactional support. Social communication is the development of spontaneous, functional communication, emotional expression, and secure and trusting relationships with children and adults. Emotional regulation is the development of the ability to maintain a well-regulated emotional state to cope with everyday stress and to be the most available for learning and interacting. Transactional support is the development and implementation of supports to help partners respond to the child's needs and interests. It modifies and adapts the environment and provides tools to enhance learning. The model is designed for social partners, language partners, and conversational partners. It's used for all children on the autism spectrum. The approach starts from least to most natural, starting with planned activities, routines, and moving towards engineered activities and environments. Next, it moves to modified natural activities and environments. The most natural level is naturally occurring events and environments. There are 7 principles of CERTS. The first one is to emphasize functional use of language in communication in natural settings. Second, emotional regulation and its effects on communication, interaction, learning, arousal states are monitored continuously. Third, the approaches to problem behaviors are integrated in social communication and emotional regulation. 4, environments are arranged and activities are designed to foster motivation and encourage initiation of communication. 5, transactional support is used to promote active and independent participation in activities. 6, learning and playing with peers is essential. And 7, positive relationships among professionals and family members is the foundation for successful collaboration.
Third time's a charm.
So I'm here with my cousin Susan and her daughter Madison. So my second cousin has autism and was diagnosed a little bit before kindergarten. So she's just here to tell us a little bit about their experience and Madison's journey and how she's come to communicate. So
I guess our first question would be, how did you come to the diagnosis of autism with Madison?
Madison basically was delayed in all of her milestones from day one. Through her doctor, she was diagnosed developmentally delayed, and we went through Babies Can't Wait and had started physical therapy at about 1 year old. She didn't even consider starting walking until she was almost 2. About a year and a half, I think we started speech, and she didn't really start talking until 3, and she had fine motor issues, so we started OT probably about 18 months to 2 years old. But basically, she was delayed through everything. She went to special needs preschool, and right before kindergarten, my husband and I had been researching all of her things and decided that we wanted her tested for autism just to see, because when she started kindergarten, we wanted her to get the services that she needed. So we requested through her pediatrician that she get tested. Nobody else ever mentioned it. It was never even an issue because they said that she'll look at you, she'll smile, she'll interact. So obviously she wasn't autistic.
If you could just tell us a little bit about how you used baby sign to communicate with Madison at a young age.
We started that. Well, I started almost immediately because I had a minor in sign language, so I had a background with it already and knew that it would probably help with communication before I even knew that she was going to have a communication issue. So we started with the baby signs, milk, more, bathroom, mom, dad, please, thank you, those kind of things. And she picked up on it really fast, and I think that it probably avoided a lot of meltdowns and frustration, because there gets to a point where the pointing just wouldn't work, but she fell back on the sign language and seemed to do really well with it.
And if you could just tell us a little bit about how far Madison has come since then.
Well, once, as far as speech goes, once she got into speech therapy and actually started doing really well with it and talking, she hasn't stopped. They quit her speech services at school probably 3rd grade because she was doing so well with it. OT, she's gotten a lot better with fine motor. They also quit her physical therapy in elementary school probably about the same time they did the speech therapy. But as far as speech goes, it helped immensely. She just figuring out how to communicate and how to talk, and she honestly hasn't stopped once she started.
All right, well, that's Susan.
Does anyone have any questions?
Yes, you in the back.